Hi there, my highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference where patient safety, medication therapy management, and optimal clinical outcomes are very, very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for very high impact pharmacotherapy services. So I humbly urge you all to sit back and spare me part of your very precious time to share with you some very useful tips which may prove very, very handy in your line of duty. So I welcome you all to part 118 of our Pharmacotherapy MCQ series, Measuring in Infectious Diseases. Welcome. And the first question reads, Mrs. WCO, a 49-year-old female patient, presents to your accident and emergency department. She has a past medical history of hypertension, and in today's visit, her chief complaint is photophobia, and she informs the clinician she has a severe headache, and since yesterday she developed fever and severe neck pain, and she has no known drug or food allergies. Some of her vitals include a body temperature of 38.8 degrees centigrade, a blood pressure of 143 systolic, 90 diastolic, a heart rate of 100 beats per minute. And on physical examination, the clinician establishes she has mucorigidity, she has a positive Carney sign, and there are no rashes on her skin. Some of the pertinent labs include a WBC count of 15 times 10 power 3, and all other lab values are within normal limits. A lumbar puncture is done after it's established it is safe, and the WBC is 200 cells per mm cubed. 20% of them are neutrophils, 70% are lymphocytes, and protein is 80 milligrams per deciliter. And the CSF to serum glucose ratio is 0.5. Blood, urine, and CSF are sent for culture and gram stain, and a head CT is done and it comes or returns negative, meaning there is no space occupying lesion or any other funny occurrence in the brain. So apart from dexamethasone, which of the following would be the best therapeutic regimen for Mrs. WCO now? Would you settle for Vancomycin, Ceftriaxone, Ampicillin, and acyclovir? Or would you settle for Vancomycin, Ceftriaxone, and acyclovir? Or would you settle for Vancomycin, Ceftriaxone, and Ampicillin? Or would you choose to infuse only Vancomycin and Ceftriaxone? I'll give you 10 seconds to choose the correct answer. The best option would be to treat this patient using Vancomycin, Ceftriaxone, and acyclovir, and I'll tell you why. This patient presents with a community-acquired meningitis. However, the CSF findings are inconsistent with bacterial and viral meningitis. Rather, they are consistent with a mixture of both. So you can't treat one and leave the other. Now, although the WBC count in the CSF is 200 cells per mm cubed and is consistent with a viral cause, the count may actually be lower in early bacterial meningitis because of the acuity of the illness. Now, the predominance of lymphocytes in the CSF indicates a potential viral cause, but the elevated protein concentration suggests that bacteria are present. Finally, the CSF to serum glucose ratio is in between the ratio that would occur in a viral, which is 0.6, and the ratio that would occur in a bacteria, which is 0.4. Therefore, all the possible likely organisms should be covered in the treatment regimen used in this particular patient's case. Now, strep pneumo, Haemophilus influenza, and Neisseria meningitidis and viral pathogens are all likely potential causes. Therefore, answer B, which is a combination of vancomycin, ceftriaxone, would cover well for the bacteria, and acyclovir would cover possible herpes simplex type 1, HSV1, and that would make answer B the correct answer. And in my opinion, A, C, and D are incorrect. Let's move to the next question, please. And it reads, Mr. J.K.L., a 39-year-old male patient weighing 75 kilos who is 70 inches tall, presents to your accident and emergency department. He is confused, disoriented, and feverish. He has a body temperature of 38.6 degrees centigrade to be specific. His lab values are within normal limits, and his serum creatinine is 0.8 milligrams per deciliter. He has a WBC count of 19 times 10 power 3, and toxicology screening returns negative. Head CT is done, and it's negative for hemorrhage, for edema, and for sinusitis. A lumbar puncture is done, and the team establishes a normal opening pressure. The WBC there is 125, and the lymphocytes are 99%, and glucose is 62 milligrams per deciliter. The normal usually is 130 in serum. Then the protein is 70 milligrams per deciliter. Gram staining is negative for bacteria. So my question to you is, which of the therapeutic options listed below would be the most appropriate empirical therapy for Mr. J.K.L. now? Would you choose to treat this gentleman with acyclovir at a dose of 1,500 milligrams infused over an hour twice daily? Or would you choose to treat him with 750 milligrams of acyclovir infused over an hour 3 times a day? Or would you choose to treat this gentleman with 2 grams of ceftriaxone infused over half an hour twice daily, alongside 2 grams of vancomycin infused over 2 hours twice daily, alongside 2 grams of ampicillin infused IV every 4 hours? Or would you settle for 2 grams of ceftriaxone alongside 1.5 grams of vancomycin, both infused twice daily? I'll give you 10 seconds to choose the correct answer. So answer B is correct. I would dose the acyclovir at 10 milligrams per kilo IV TDS to treat viral encephalitis. The patient presented with signs and symptoms of viral encephalitis, and the lumbar puncture is most consistent with viral etiology. Now, because the gram stain is negative, the lumbar puncture is inconsistent with bacterial origin, and that makes answers C and D incorrect. Now answer A, in my opinion, is incorrect because 20 milligrams per kilo dosing of acyclovir is reserved for infants and children and should be administered every 8 hours in that population instead of every 12 hours. Let's move to the next question, please. And it reads, Mrs. J.P.O, a 29-year-old female patient who is 65 inches tall and weighs 65 kilos, presents to your accident and emergency department with a chief complaint of headache. She is confused and a bit feverish with a body temperature of 39.1 degrees centigrade. Her labs are within normal limits. She has a serum creatinine of 0.7 milligrams per deciliter and her WBC count is 19 times 10 power 3 cells per mm cubed. Her head CT is done and it is negative for hemorrhage, for edema and for sinusitis. A lumbar puncture is done and the team establishes that the opening pressure is elevated. The WBC is 1,250 cells per mm cubed. 99% of them are neutrophils. And the glucose is 20 milligrams per deciliter. Normally in serum the level should be 110 milligrams per deciliter. And the protein is 300 milligrams per deciliter. Gram staining is pending. So my question to you is, which dexamethasone regimen listed below would be the most appropriate in J.P.O's case? Would it be dexamethasone 10 milligrams IV QID, that is every 6 hours, should be administered 24 hours after initiating antibiotic therapy? Or is it true that dexamethasone 2.5 milligrams IV every 6 hours should be administered before antibiotic therapy? Or is it dexamethasone 10 milligrams IV 4 times a day should be administered before antibiotic therapy? Or is it true that dexamethasone should not be considered because this patient appears to have viral encephalitis? I'll give you 10 seconds to choose the correct answer. C would be the correct answer. C would be the correct answer. Now, dexamethasone 10 milligrams IV administered 4 times daily should be administered before the antibiotic therapy. Now, the CSF findings above of the lumbar puncture, in my opinion, are consistent with bacterial meningitis. Therefore, dexamethasone should be administered at the dose specified in C. Or at least it should be administered concomitantly with the antibiotics to prevent complications. Now the answers A, B, and D, in my opinion, are all incorrect. Let's move to the next question, please. And it reads, which of the antimicrobial regimens listed below would be the most appropriate for Mrs. J.P.O in the previous clinical case? Would it be 2 grams of ceftriaxone infused over half an hour after dilution in normal saline once daily, alongside 1,250 milligrams of vancomycin diluted in normal saline and infused over 2 hours twice daily, together with 2 grams of ampicillin infused every 4 hours? Or would it be B, 2 grams of ceftriaxone twice a day alongside 1,250 milligrams of vancomycin infused twice a day? Or would you settle for 1,300 milligrams per kilo of acyclovir infused thrice daily? Or would you settle for 650 milligrams per kilo IV thrice daily of acyclovir? I'll give you 10 seconds to choose the correct answer. I would settle for 2 grams of Ceftriaxone infused over 30 minutes twice daily alongside 1,250 milligrams of vancomycin infused over 2 hours twice daily. Now, because of the origin of this infection, it is likely to be bacterial. Therefore, antibiotics and not antivirals such as acyclovir are indicated and should be administered. That makes both answers C and D incorrect. Now, in my opinion, answer A is incorrect because there is no indication to administer ampicillin. This patient is unlikely to have Listeria monocytogenes as the pathogen causing the meningitis because of the age limit. She's not above 50. Therefore, that leaves us with B as the correct answer. Let's move to the next slide, please. And the next question reads, which of the sets of immunizations listed below is recommended in pediatric patient aged 2 years or less? Is it the pneumococcal polysaccharide vaccine, the PPSV23, alongside the Haemophilus influenza type B vaccine, the HIV, and the meningococcal vaccine and the Listeria vaccine? Or would it be the PPSV23, Hib, and the meningococcal vaccine alone? Or would it be the PCV13, Hib, and meningococcal? Or would it be the PCV13, Hib alone? I'll give you 10 seconds to choose the correct answer. So D will be the correct answer. I would recommend the PCV13 and the Hib vaccines. And that is the recommended regimen for children under 2 years. Now, the meningococcal vaccine is only recommended in children with asplenia, HIV, or complement deficiency. In my opinion, answers A to C are all incorrect. And I'd just like to emphasize that there is currently no vaccine for Listeria. So that makes A totally wrong. Let's move to the next question, please. And it reads, Master T.K.K, a 6-year-old boy, is brought to your pediatric accident and emergency department with signs and symptoms such as fever, headache, vomiting, and his mother informs the pediatrician in her own words, he hasn't been his normal self. He has shown increased irritability for the past 2 days. Master T.K.K completed a 10-day course of co-amoxicillin 3 weeks ago for acute otitis media, AOM. He has a past medical history of cochlear implants, and he is up to date on his vaccines. And this boy has no known drug or food allergies. And some of his pertinent labs include a basic metabolic panel that is within normal limits. His CBC is notable for a WBC of 13.2 times 10 power 3, and all other values are within normal limits. Now the vitals include a body temperature of 38.8 degrees centigrade, a blood pressure of 100/63, a heart rate of 70 beats per minute, a respiratory rate of 22, and a lumbar puncture is done 24 hours later, which shows an opening pressure of 210 millimeters of water, and the CSF is analyzed. The WBC is 1,800. The lymphocytes are 4%, monocytes are 1%, neutrophils are 95%, and there are no eosinophils. So the report says the neutrophils predominate, and the glucose is 25 milligrams per deciliter. The proteins are 100 milligrams per deciliter according to that report. So my question to you is, which of the LP results listed below suggests that T.K.K. has bacterial meningitis? Is it low glucose, low protein, and a high white blood cell count with neutrophil predominance? Or is it B, low glucose, high protein, and low white blood cell count with neutrophil predominance? Or is it low glucose, high protein, high white blood cell count with the neutrophil predominance? Or is it high glucose, high protein, high white blood cell count with neutrophil predominance? I'll give you 10 seconds to choose the correct answer. So in my opinion, C is the correct answer. Low glucose, high protein, high white blood cell count with neutrophilic predominance is the correct answer. Now, community-acquired bacterial meningitis most often is associated with a CSF analysis showing low glucose, high protein, high WBC with neutrophilic predominance. Now I would like to refer you to a table in the next slide. Which compares typical CSF WBC, CSF glucose, and CSF protein observed depending on whether it's a viral, bacterial, or tubercular meningitis. So I would advise you to either pause the video or revisit this slide at a later stage. So let's move to the next question, please. And it reads, which of the antibiotic regimens listed below would be the most appropriate for T.K.K's case above? Would you choose to treat T.K.K with ceftriaxone, dosed at 100 milligrams per kilo per day in 3 divided doses, alongside vancomycin at a dose of 60 milligrams per kilo per day in divided doses 4 times to 3 times daily? Or would you choose to treat this patient with meropenem dosed at 120 milligrams per kilo per day in 3 divided doses alongside gentamicin 4.5 to 7.5 milligrams per kilo per day once daily? Or would you settle for 100 milligrams per kilo per day of ceftriaxone in divided doses twice daily alongside 60 milligrams per kilo per day of vancomycin in 3 to 4 divided doses? Or would you settle for 200 milligrams per kilo per day of ampicillin administered in divided doses every 3 hours to 4 hours alongside gentamicin dosed at 4.5 to 7.5 milligrams per kilo per day as a single daily dose? I'll give you 10 seconds to choose the correct answer. C is the correct answer. I would settle for ceftriaxone, 100 milligrams per kilo per day in 2 divided doses, both infused over half an hour, alongside vancomycin, dosed at 60 milligrams per kilo per day in 3 or 4 divided doses, each infused over at least an hour. Now, for bacterial meningitis, in a 7-year-old patient where the pathogen is likely to be strep pneumo or Neisseria meningitidis, it is recommended to start such patients with ceftriaxone 100 milligrams per kilo per day in divided doses BD twice daily, in addition to vancomycin dosed at 60 milligrams per kilo per day in 3 to 4 divided doses, and we add the vancomycin just to cover empirically, and that is consistent with the IDSA guideline recommendations. Now, cefazolin does not provide adequate coverage, and it does not penetrate into the CSF, the CSF well. It doesn't penetrate the blood-brain barrier effectively, and I would like to add that meropenem with gentamicin would cover both pathogens. However, it is unnecessarily broad spectrum. That would be an overkill. Then I would like to add that ampicillin with gentamicin would not provide broad enough coverage in this particular clinical scenario. So there you have it, my highly esteemed viewers and listeners. That brings us to the end of this video. If this video benefited you in any way, I would like to remind you to give it a thumbs up, to like it, and to share it widely with your peers, and to leave your comments at the very bottom of the video. And if you haven't done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very best is yet to come. Thank you all very much for viewing this video and for listening to me. I sincerely appreciate your partnership, your continued support, and your very, very kind collaboration. And I look forward to interacting with you all in part 119 of our Pharmacotherapy MCQ series. Thank you very much.